I'm Lathey. I'm one of the ST9 dual intensive care anaesthetic trainees. I'm finishing my training in Mid Yorks at the moment, and then I'll be joining the team in Leeds in the summer as an intensive care and anaesthetic consultant. And as it's been introduced, I'm one of the weird hybrids of intensivists who also have an interest in obstetric anaesthetics. Although I do think it's an evolving specialty, and we're lucky in Yorkshire to have Debbie Horner, who's leading quite a lot of the maternal critical care work, and we've got a few trainees coming up behind me who are interested. All I can say to start off with is I'm really sorry, because I appreciate most of my ICU colleagues think that I'm a weirdo for liking obstetric anaesthetics, and I imagine that many of you as obstetric anaesthetists probably dislike intensive care medicine, and I'm now going to talk to you for 20 minutes about exotoxins, so I can only say sorry in advance for all of that. What I want to do today is just give you an intensivist input really into sepsis, and that will cover some of the new sepsis understanding and how we define it and score it and risk stratify that. Then overlap it with some of the challenges that we know pregnancy poses in sepsis management, and then talk about how we as intensivists would manage the peripartum patient who's admitted to critical care with sepsis. And I lastly want to finish off with some of the really troubling sepsis diagnoses, so group A strep, neck fash, and the atypical pneumonias, the things that I know we are seeing commonly in the obstetric populations, or more commonly than previously, and make us all a little bit sweaty palms when we get them on ICU. So the traditional teaching of the sepsis definition, as you'll remember from medical school, is the SIRS response coupled with a source of infection. But that definition has been changed from the Sepsis 3 consensus, which came out in 2016. And now there's an increased understanding that sepsis is much more complicated than just a SIRS response plus some infection. The reason this has all come about is because, firstly, SIRS responses aren't always indicative of dysregulation, so it can be a normal physiological process to infection. And it's present in many hospital patients, so it's not really particularly specific to sepsis. When we look at the ICU patients who are coming through with multiple organ failure relating to sepsis, 1 in 8 of those don't even meet 2 out of those 4 SIRS criteria, and you'd expect that you need something a bit more specific if you're going to be screening for it on ward. So now, the international consensus, which is led by the European Society of ICM, has recognised that the sepsis response we see is multifaceted to the infecting pathogen, but there's lots of endogenous and exogenous factors that play into that. So whether the patient's got comorbidities, are on certain medications, what the source of infection is, whether they've had recent surgery or have been or are pregnant. So it's much more complex than we previously thought. The septic shock definition is previously similar to this, in that once you've defined sepsis as this life-threatening organ dysfunction with a dysregulated host response, if the patient then needs vasopressors to maintain a MAP of 65 and or have a lactate over 2, then they meet that criteria. And we know that patients who meet that septic shock criteria have a 40% mortality once they reach ICU. So how do we know if a patient has got organ dysfunction as a consequence of their sepsis? Well, the Sepsis 3 campaign uses this SOFA score, and as you can see, it's a lot more complicated than SIRS. So there's 6 parameters looking at the presence of hypoxia, thrombocytopenia, impaired liver synthetic function, looking at bilirubin as the marker, the presence of hypotension, altered GCS, and acute kidney injury. And although this is much more sensitive and specific, if you're looking after patients in a ward environment, it takes a long time to diagnose all that, waiting for labs to come up, and can be quite complicated for patients, for healthcare professionals who aren't used to looking after patients with profound sepsis. So on the right, you'll see this is taken directly from the Sepsis 3 consensus. If you've got a patient with suspected infection, they recommend using a quick SOFA score, which is similar to SIRS, but it's only got 3 parameters, so tachypnea, altered mental state, and hypotension. And if you've got 2 out of 3 of those, you then would go on and do a full SOFA score, or it should prompt you to be looking at their coagulation, their liver synthetic function, their kidney function, for example. In addition to all of this, there's an increasing recognition that maternal sepsis is an entity of its own, and the WHO have recommended, have produced a statement really defining that it's its own condition in its own right. And it's really important because women in the UK are still dying of sepsis in the peripartum period. This is from Embrace report, which we've seen a lot of today, but specifically looking at maternal deaths relating to infection. And as you can see, between 2019 and 2021, there were 87 deaths in the UK relating to infection. The grey line here is COVID, so if we ignore all of that and hope that that never shows its face again, there are still 33 deaths related to infection. Just under half of them were direct causes, so genital tract infections, chorioamnionitis, septic miscarriages, for example, and then just under half being the non-direct causes, mainly pneumonias, meningitis and myocarditis. Why is managing sepsis in the peripartum period more challenging? And certainly my intensive care colleagues get very twitched when we admit an obstetric patient, and there's a few reasons for that. Firstly, we know that the patients are already naturally immunosuppressed by means of being pregnant or in the early postpartum period. And in addition to that, they're then exposed to procedures and surgery which can introduce a path for infection. And finally, a lot of the pregnancy physiology mimics the features of sepsis, so it makes it harder for us to pick up on a labour ward or antenatal or postnatal environment. Looking at some of these differences, we know that in sepsis, one of the earliest markers is tachypnea, and that's because of increased permeability in the pulmonary vasculature and early acute lung injury. So we, in non-pregnant patients, use tachypnea as a marker, an early marker of deterioration, but that's really difficult in pregnancy when we accept that patients have already got an increased tidal and minute volume. Similarly, with changes in blood pressure throughout pregnancy, it can be really difficult to score who's becoming sepsis or who's just got natural pregnancy physiology. And the presence of tachycardia can be labelled as normal pregnancy physiology when actually it's an evolving sepsis picture. In both conditions, you're pro-thrombotic, and that's really important in pregnancy-related sepsis because we all think of DVT and PE risk. But in a septic, pregnant or postpartum patient, you also get increased microthrombi, so you can get increased end organ dysfunction because of that. And on top of all the physiology, it's really difficult to diagnose sepsis because we know that it's natural to have a slightly raised white cell count. There can be an increased temperature and lactate in labour. So as intensivists, we would be using the white cell count and CRP to guide it, but it can often be misconstrued as normal pregnancy changes. I put a question mark by procalcitonin. That's a marker that we're using in most ICUs around the region, not all at the moment, as a specific marker of bacterial sepsis. It's brilliant in most patients because there are certain situations where patients might have a raised white cell or CRP because of steroid use, viral infections, trauma, but the procalcitonin is really specific to bacterial sepsis. The issue we've got is that all of the PCT studies exclude pregnant women. So not only would it be a brilliant marker for us to use, but there's no evidence of whether we can use it and what the reference ranges are. Some of the trials are suggesting that the procalcitonins can be a little bit elevated in pregnancy naturally, so we don't know what the normal reference ranges are, and currently it's not in NICE guidance to use it. Pragmatically, as an intensivist, it can help build the picture to diagnose sepsis and guide treatment, and we could use it potentially to monitor trends which help us know whether antibiotics are working or not. But in the literature, it's not currently recommended to use. To top it all off, once we've realised that it's really hard to pick up sepsis in pregnancy, it's then really difficult for a pregnant or postpartum patient to cope with being septic. And that's for a few reasons. As we know, they'll rapidly deoxygenate, which is a problem if you've then got another confounding cause of respiratory failure. Find it very hard to compensate for metabolic acidosis because they've got a natural respiratory alkalosis, are prone to cardiovascular collapse, and as we said earlier, are more likely to get end organ dysfunction because of microvascular thrombi. Once we've picked it up late and they're already immunocompromised, patients can present to us on intensive care with multi-organ failure. And in addition to the biochemical changes we see in terms of immune markers, it can also be difficult to pick up on acute kidney injuries because, as we know, in pregnancy it's normal to have a slightly low urea concentration. So if the urea looks normal, especially to intensivists who don't do much obstetric work, they can presume that patient doesn't have an acute kidney injury when actually they do, and it's masked by the low concentration of pregnancy. So, as I showed you earlier, the Q-SOFA and SOFA scores use specific parameters, but we need to accept that some of those parameters don't work in pregnancy. And these markers, as a modified SOFA and Q-SOFA, which is used in the Australian and New Zealand Society of Obstetric Medicine. So these are adapted risk scoring systems for sepsis in the pregnant population. One example here is the respiratory rate. So in pregnancy, you'd only score 1 when you've got a breath rate over 25, whereas in the normal SOFA score it's 22. So it's adapted to try and make sure that we're more precise in what we're picking up on. It's not used in the UK currently, although some of you may be aware that we're about to get a national maternity early warning score system. I've had a little sneak peek at that and it's really good, so hopefully we'll get it soon. But hopefully we should be getting more tailored early warning scores for sepsis and deterioration in the UK. What we do have already is this from the UK Sepsis Trust, a really, really aggressive maternity and sepsis trigger tool. Start shouting at you at various points, but it's actually really useful in terms of making sure you've thought about infections that aren't typical for the non-pregnant population and making sure that the right things are happening and that patients being escalated, and that's just on the UK Sepsis Trust website if you don't use that already. So, what can we do in intensive care to manage this situation that we've already said is really difficult? Well, firstly, we need to look out for the patients who are most prone to getting infection. And patients with all of these conditions, and often in combination, we need to have a really low threshold for considering sepsis, in addition to whatever else is going on in isolation. So the supportive measures that we use are actually really similar to the non-pregnant population. From a respiratory perspective, we're all using lung protective ventilation strategies to reduce the risk of ARDS and barotrauma. For those who haven't done ICU for a little while, it's 6 mils per kilo tidal volume, having a reduction in peak and plateau pressures and high peak strategies. But increasingly we're recognising that overzealous fluids are harmful to patients in general in ICU, so we're aiming for targeted fluid management and normovolemia. To give you an idea, 20 to 30 mils per kilo and above is deemed as excessive, and in your average 70 to 80 kilo pregnant woman, that's only 1.5 to 2.5 litres, presuming that they're not already in a fluid deficit in terms of resuscitation, and any more than that, you're looking at using vasopressors to try and control their blood pressure. Otherwise, we know that they're at risk of having complications and prolonged length of stay in ICU. Handily, there's quite good evidence for using the same vasopressors that we use in the non-pregnant population, so noradrenaline is still our first line and vasopressin is the second, and a target map of 65 should be sufficient in preventing secondary organ dysfunction. We use lots of care bundles in ICU, which are all applicable to the peripartum patient, but we need to be making sure that we've got focus on VTE prevention and glycemic control. We know that having good glycemic control improves outcomes in all of our critical care patients, but it's even more important if the patient is still pregnant, where persistent hypoglycemia could be detrimental to the fetus as well as mum. So what are the specifics of treatment that we do? So firstly, broad spectrum antibiotics are really important. When patients are in an antenatal or postnatal environment, they're often covered for maybe the obstetric specific infections, but we know the patients that come to us on ICU have often got a mix of bacteria, polymicrobial, and the two organisms that have got the highest maternal mortality in this patient population is the group A streps and E. coli, and you can only really cover those by giving them tazocin or meropenem in combination with clindamycin, which we'll come on to later. So if you think you're picking up a patient who's got signs of severe sepsis, it's worth escalating them antibiotics early or something a bit different to what you usually use on labour ward to make sure you've got the strep and the E. coli cover. Steroids is pretty interesting. As you'll remember, steroid management for refractory hypotension is always in and out of vogue. It's currently in favour after the back of 2 really big trials, one showing that patients did a bit better the other showing not much difference but a reduction in length of stay. So currently in sepsis in the non-pregnant population, we're using steroids for refractory hypotension. That's normally at the point where patients have moved from 1 to 2 vasopressors, and adding in steroid at that point is the most common practice around the region, certainly. The difficulty we've got is that there's no recommendations for using steroids in pregnancy, probably because of lack of data. In the US, it is in their refractory septic shock guidelines, and pragmatically, I think if you've got a woman that's that sick that they need double vasopressors, most intensivists would probably consider the benefit of adding in steroid outweighs the risk, but in terms of guidelines and literature, the evidence isn't there currently. Source control is really important, and we'll come on to this a bit later when we look at some of the maternal deaths relating to infection, because there's often a reluctance to control the source, whether that's drainage of abscess or collection, or not able to find where the collection or abscess is. But actually, if you've got something like a group A strep infection, controlling the source early is really important. From our perspective, we always worry about when should we deliver the baby. The literature out there, although we can obviously take expertise from our obstetric colleagues, is that in terms of improving infection, the only indication for delivering baby is in the context of chorioamnionitis. And in the rest of the situations, we can be guided by our obstetric colleagues, and the usual obstetric indications are there. So it's not necessarily going to help mum or baby in terms of delivery, and it's something that we would be liaising with our obstetric colleagues about. IV immunoglobulin used to be a bit of a witchcraft and just throw it around with no real indication, but in the last few years we've seen some more data coming out about the benefits of IV immunoglobulins in the context of severe staph and strep infections. So if you get somebody who's got a really nasty staph or strep bacteremia or invasive staph or strep, there is evidence that giving IV immunoglobulins quite early, so rather than waiting for them not to respond to antibiotics, but giving it within the first 24-48 hours, can neutralise all of that inflammatory response and prevent the huge cytokine storm they get with these conditions. So we're seeing an increasing role of IV immunoglobulins, which we can give really quite easily on most ICUs around the region. Finally, I've put ECMO in there because it's commented on quite a bit in the latest Embrace data, where they really want to even out access to ECMO. I think probably the only good thing that came out of COVID was that we saw an increased number of maternal patients who required ECMO, and we've seen the survival rates are really good. So we should probably be ensuring that we can get ECMO access from ICU a bit earlier than we do. For us in this region, it's either Wythenshawe or Leicester. So, to finish off, I just want to talk about some of the really scary infections that we struggle to manage on ICU, and the ones that I think would make us all, whether we're in an anaesthetic context or an ICU context, pretty nervous. The group A streps are a weird organism really, in that around a third of the population can be carrying it asymptomatically. It can give you a bit of a sore throat, a bit of mild cellulitis. But when the group A streps are invasive, and by that it means being in a normally sterile site, so the lung, the endometrium, the joints, the brain, or deep skin infections, that's when it can cause a massive inflammatory response. Unfortunately, these types of streps can produce exotoxins, and they really ramp up the inflammatory system, so they're called super antigens, which I think probably an American term, leading to over-activation of the cytokines, interleukins, and patients have profound shock and multi-organ failure and often die within 24 hours of coming to us on ICU. The difficulty we've got is that it's quite hard to pick them up, but you don't want to be waiting for culture results to come back. And it's about thinking about when, if somebody's really sick and they've got infection somewhere that's not adding up, so if they've got a septic arthritis but they're really, really poorly with multi-organ failure, is this an invasive group A strep? And in which case we need to make sure that the antibiotics include clindamycin, because clindamycin has the potential to switch off that exotoxin production, so to limit the damage that it's doing. Of note, the patients, if you think have got group A strep, should be isolated in whichever environment that they're on, and it's a notifiable disease because it can spread throughout the community.
1 minute.
I've included a bit on neck fash just because it's one of the causative organisms for neck fash, although there's lots of other ones we can use here. And as you know, with neck fash, treating it quickly, debriding it and giving antibiotics that contain clindamycin is really important. But there's also now a recognised role for IV immunoglobulins in this patient group too. I put 2 atypical pneumonias in. One because it's absolutely awful when you get them, and the other because we're currently in an endemic, so you might see them on label a bit more. So the PVL staph on the left is a type of Staph aureus pneumonia. It can be an MRSA or an MSSA, but the staph produces a PVL gene which creates cavitating bilateral lung lesions with a hemorrhagic pneumonia, and they almost all die when they get it, so it's absolutely horrendous. If someone's really sick with pneumonia, you can send off PVL testing to see if they've got PVL staph, but you need to be making sure they've got linezolid or clindamycin on board and speak to micro. Mycoplasmas don't make people that sick that they need to come to ICU, but they can be poorly on labour ward. Pregnant women more common to get it because there's often circulating in younger children, so if they've already got kids at home, they might get it. Normally not too much of a problem, but every 4 to 7 years it rears its head, and this year we're seeing a bit of mycoplasma coming onto ICU, and that's why we give clarithromycin cover if we're treating CAPS. So that's what that's to treat. And you can test for that, as you know. So just have a little think if someone's a bit poorly. Finally, I've included a reminder of the local HSV alerts that are out, primarily looking at transmission of HSV from mums to babies, but also to remind ourselves that in extreme cases where mums are also immunocompromised, such as those with HIV, you can get disseminated herpes, which is absolutely awful if they get it. And it's just to be aware because this is circulated around the region at the moment from the obstetricians, and I felt that it was worth us being aware of it as well. I finished off without a long summary, but I'm just going to leave those there for people to have a read of. These are all comments from the Embrace report when women have died of maternal sepsis. And although we can talk about exotoxins and clindamycin and IV immunoglobulins, the themes are really common in that the lack of recognition, delay in starting antibiotics, and a reluctance or lack of source control, and maybe not necessarily listening to the mums when they come in and say something's not right. That's probably more important than anything we can do on ICU. So I'll leave those there as a reminder. That's all. Thank you.
Hi, thanks. I think I'm still the sole obstetrician in the room, not unless we've got anyone. Really lovely talk, thank you so much. And I think you know that I'm interested in this as well, because I'm joining your crew. This is such an important topic. And I'm glad you've mentioned the women that died with disseminated herpes. I think some of you might recall a woman that we had in Leeds, before I left Leeds, that had group A strep, and that took her and shook her. She was an elective section for maternal request. And group A strep went through her like a dose of salts. She survived, but just, and that sticks with me. And I think the team, when she came back into the hospital, I was on delivery suite that day, and the team were rapid in recognising that this was a woman that needed sorting out. And although the baby was out of the uterus, I remember I took her to theatre with one of the gynecologists, and there wasn't anything much to find in her abdomen. It was, I think some of you that were involved may remember, there wasn't anything to find, but she was really, really sick. So this is something that really reaches inside and resonates, so thank you very much for doing such a good job and such an excellent presentation. The other thing was about decision for delivery for baby. Crikey, so that is a multifaceted. I don't need to tell anybody in this room. That's a proper multidisciplinary discussion. I think the earliest to save mum, if mum is dying and there is a problem and we think baby needs to be delivered, we will get on and do that. If there's a chance that we'll be able to survive, keep the baby alive, etc., that's what we will do. But it's a big discussion because for obstetricians it will involve talking about steroids. You talked about that. We would give those for fetal lungs. We give steroids quite a lot in obstetrics, not with sort of like Smarties, but we're really careful. If we're going to deliver the baby within a week, we'll give steroids. Mag sulfate at the less than 32 weeks of fetal neuroprotection. And the woman ideally has to be in a place that if she's going to be delivered of her baby within a certain gestation, she needs to be in a place where there is appropriate level of neonatal unit to catch the baby. If mum's really sick, then transfer is the other issue as well. So I'm going through all the things with a microphone in my hand that will be going through my mind. But of course, it's a really difficult decision. And every decision about delivering baby is going to be individualised to the woman and to the care that can be provided and to how far down the line she is with the sepsis, because it's easier to make decisions when you're in that early stage, but when you're really far down the line and they're more unstable, it's very, very difficult. But I'd be interested to hear other people's thoughts, of course, not obstetricians, but any other thoughts, please.
Thanks, it's all really useful. I think regardless of when or why mums are poorly, there's an increase in recognition that ICU need to be doing better with peripartum patients, and we're really lucky in Yorkshire that we're actually leading national work to try and do that, but loads of work needs to be done, so if anyone's interested, there's plenty to go at. Lots of people are already helping me. Thank you.
Wonderful. A useful point. The mic is there.
Yeah, we had I wasn't really involved in it, but we had a maternal cardiac arrest on ITU which involved a caesarean section. So I think if you have got women that you may well be delivering, you need to have the kit. In our case, the baby was delivered really quickly.
Yeah. So the GPIC standards that we have in ICU say that you have to have the equipment to perform a perimortem section immediately at the bedside. But having said that, anecdotally, when you work in the intensive care units around the region, the kit's not there. I know that you don't need a huge amount of complicated equipment, but it needs to be somewhere that's labelled that anyone can grab. So in Leeds, certainly, we're just introducing a checklist so that when patients arrive in the peripartum period, it's obvious where that equipment is and that someone's acknowledged that we've looked to make sure we've got something on the unit and made a little bedhead sign for the back saying, in the case of cardiac arrest, put left lateral tilt on, and this is where the kit is. But most units around the region, this region certainly, don't have a designated area of where they would have the kit to perform a perimortem section. And so work's happening certainly in Leeds, in York, in mid-Yorks at the moment. So yes, there's plenty going on, but it's really scary that when patients feel poorly, we're not necessarily equipped as intensivists to deliver or deal with obstetric-specific complications. So I think that's recognised increasingly now.
I think that's a really good point you've raised about kit for perimortem section. It isn't available. I did a talk for the RCM a little while back about perimortem section, or resuscitative hysterotomy as it's called, and that sounds really fancy and quite scary, and it kind of is. It's a scalpel, that is it.
Which we've got.
And that is it. It's a scalpel, and it's 4 minutes from decision to get baby out, and it's to resuscitate mum. But I think I've done a talk on it. I think it's online. I'm happy to share. But I got a complaint after the talk that there was a demonstration, and I had to go on YouTube and get and use a simulation. And somebody said, "Well, that's a waste of time. A YouTube simulation." I said, "Yeah, but they're not going to be filming somebody having a section." So you're absolutely right. There isn't a lot of places don't have a kit, but any obstetrician, I would say, grab it literally is a scalpel. That is it.
So thank you very much. I think we're running out of time. So I think we'll conclude the talk, and thank you very much for